Namrata, please.
Thank you so much, Dr. Srinivas Rao. I'll be talking to you about management of Steven-Johnson syndrome and toxic epidermal necrolysis. The incidence is 2 per million, but we see a lot more in India, and also we see it in a more severe form as compared to the West and the East both. It is associated with the use of antibiotics, antiepileptics, and NSAIDs, and CMI and antibody mediated immunity is involved in it. Now, it is of various forms depending upon the severity, erythema multiforme, SJS, SJS toxic epidermal necrolysis complex, and frank toxic epidermal necrolysis. Acute SJS, the ocular symptoms will present within 2 to 6 weeks after symptoms. The ocular manifestations are seen in 50 to 80% of the cases, and one third would have long term sequelae. So, patients may have bilateral conjunctivitis with the conjunctival and corneal ulcerations, hyperemia, pseudomembranes, early symblepharon, corneal shortening, and mebomitis. And this is a very important paper on natural history of SJS published by Dr. John Dart's group. And just to summarize, these are the manifestations. There will be variable degree of scarring, which will lead to dry eye. And if you have a picture like this, you'll probably just label as dry eye and not as acute SJS. And this can lead to a variable amount of conjunctivalization, keratinization, with fornix shortening leading to entropion and limbal stem cell deficiency as well. And this is the absolutely bone dry eye. So the effects are there on of dry eye, of trichiasis. So there can be epithelial defects, there can be melts like this, and then there can be vascularization and lipid keratopathy and delayed surface failure, which can be seen in these pictures along with limbal stem cell deficiency. And sometimes you can even have recurrent SJS, severe inflammatory ocular episodes as well, which are acute episodes which are on chronic SJS. And the disease is indistinguishable from ocular cicatricial pemphigoid, which again can present similarly as seen in these pictures. Then there can be late scleritis also, which is more of, again, an immunological response. And it can be an interplay of all these features which I have already discussed. Now, the goal of therapy in these cases is to control acute inflammatory reaction. This is very important because if you control it, treat it in the acute phase itself, you would probably not have a chronic sequelae. And that is the reason why we thought of doing this presentation. And so timely slit lamp examination is very important for epithelial defects. Regular sweeping of the fornices is important, and one must prevent formation of pseudomembranes in symblepharon. So the treatment modalities are following, and I would be going through these as we would go through the cases. So as soon as you have an acute case of Steven-Johnson syndrome, which is referred to you or comes to be seen by you, important thing is that you do an immediately amniotic membrane graft. I think that has a very important role to play, has been shown in now multiple studies. And topical steroids, I like to give, although people do say that the role is uncertain, and even IV methylprednisolone has a role to play. Now, immunosuppression has a role to play because what happens if you don't immunosuppress them, they would go into chronic sequelae, and more so when there are recurrent conjunctival inflammation in SJS and in acute SJS when there are inflammatory episodes. So, although in details we cannot discuss it, but this is the immunosuppressive therapy that we use, and it is all of them have different mechanism of action, and avoid mixing the drugs in the same color group. So you could either start a prednisolone or steroid and combine it with immunosuppressive agent if the inflammation is prolonged, and then the steroids can be tapered and the immunosuppressant agent can be given. And this is the systemic immunosuppression chart that we used to follow at Moorfields Eye Hospital, wherein I learned the principles of SJS, ocular SJS specifically. So all the side effects would come into this, and these side effects are listed at the back. So every time the patient comes, you know what is the dose and you know what is the side effects and what you have to monitor. And these are then slowly tapered as the inflammation is taken care of. And the endpoint of inflammation is that the eye should be white. It should not be a hot, angry looking red, congested eye, inflamed eye, inflammation of the ocular surface, conjunctiva, as well as cornea. So, and when you have to taper it, then you again go in a step ladder pattern. So you start with Depson or sulfapyridine in mild inflammation. If it doesn't work, then methotrexate, then isothioprin or mycophenolate. Mycophenolate is safest in these cases, then cyclophosphamide, and followed by IV immunoglobulins. There are cytokine inhibitors which have been tried, but of course you require the help of an immunologist if you try to give these. We did try to study the conjunctival microbial flora in ocular SJS, and we found that staph was the one which is most common because the ocular surface is altered, so the microbial flora is also altered. Now, lubricants do have an important role to play, and in the various studies on SJS, these were the lubricants which have been tried. So you can see that most people preferred preservative free because the frequency it has to be very frequent, and it could be either a CMC, hypomellose, sodium hyaluronate, or any other agent. And IV pulse therapy by Dr. Kinoshita's group has shown that it does decrease inflammation. Again, there are not enough evidence for systemic steroids and IV immunoglobulins because of lack of studies. We did do a study of use of topical cyclosporin in acute SJS, and all the parameters we found, this was a randomized controlled study, were comparable except for corneal vascularization, which we found less in cases where topical cyclosporin A was given as compared to the control group. AMG has a very important role to play, and this was the randomized controlled study that we did for AMG in 50 eyes. And in one group, we did AMG, and in the other group, we did not do AMG. And we found that the tear breakup time was better in those cases where we had done AMG. So, Sharma test was also better in those cases where we had done AMG. And so was conjunctival congestion, which was much less. And you can see the cases where AMG was done is looking so white and so uninflamed as compared to the cases where AMG is not done and only medical therapy was done. Again, Simlifron was more in those cases where we had not done an amniotic membrane transplantation, and this is the medical therapy group. Corneal haze was more in cases where we had not done the amniotic membrane transplantation, and this is the medical therapy group. Again, vascularization was less in those cases where amniotic membrane transplantation was done. And this is the group where it was not done. So you can see that conjunctivalization, limbal stem cell deficiency is also more. And so it is important in these cases to do amniotic membrane transplantation in the acute phase itself to prevent all these complications. And we started to think that it would now, if we look at the study, it will be ethically wrong not to do amniotic membrane transplantation in these cases. Look at the keratinization which has occurred in the medical therapy group. So it is very important that AMT be performed in this. Uh, the second part that I want to highlight is outcomes of COMET in eyes with chronic SJS, which has been published just this month in in American Journal of Ophthalmology. Again, in this case, in this we looked at 45 cases, and we described a new method of evaluation of grading of ocular SJS in patients with SJS, mainly because our cases tended to be more severe. So in the previous grading where Gregory has given grades which are less severe, he's gone from score 0 to score 3. But we like to add 4 and 5 also to it and look at this gamut of cases which is more severe, and you cannot put them in same as grade 3. And this has been published. So whatever COMET panels we took, we did subjected to the molecular studies, and this is the outcome. Patients did become ambulatory, and they were removed from the blindness category after doing COMET. And although they will not obtain 6/6, but still they will be ambulatory and will have 6 by 60 or 6 by 24 vision, which is good enough. And for all the parameters, we found that there was a difference, whether it was opacification, vascularization, best corrected visual acuity. And again, look at all the corneal parameters, the eyelid parameters, the conjunctival parameters, where COMET did make a difference in these cases. So I would like to conclude that acute SJA should be managed by AMT best, and that way we can prevent a lot of dry eyes and lot of limbal stem cell deficiency. And different grading is required in Indian population as our diseases are more severe. COMET has a role to play in improving ocular surface parameters and the visual acuity. And like for all conditions of dry eye, lubricants are the mainstay for the symptomatic treatment. And these are some of the review articles that have been done by SJS, where our group was a part of it. Another one, this on survey of ophthalmology. And I would like to acknowledge Professor John Dart, who introduced me to this ocular manifestations of SJS and OCP when I did my fellowship with him. And the entire team from RT Center AIMS, as well as from the main department AIMS, who are part of all these studies that we have conducted. So thank you very much for your kind attention.